my name is Silke Walter. I'm a neurologist working for Saarland University, and I have been involved in work with mobile stroke units for many years. And it's my great pleasure to be here together with my co-chair of this new ESO guideline.
My name is Georgios Tsivgoulis. I'm a vascular neurologist in the University of Athens. I was co-chair of MSU guideline, and I was mainly involved in analyzing all available observational and randomized data of MSU application in acute stroke care.
Well, shall I go on with the background on MSUs? MSUs were actually first described in 2003 by Klaus Fassbender, and that was a time when we just had intravenous thrombolysis for acute ischemic stroke patients. But the challenge was that not many patients got treated. And when they got treated, that was quite late. So they arrived at hospital quite late. And I think that was his idea to change the concept and investigate whether taking the hospital to the patient instead of taking the patient to hospital could bring benefits for the patient. And the first ambulance was on the road in 2008. That was in Homburg, southwest of Germany. And then many other centers followed: Berlin, Houston, Cleveland, and Fredrikstad, that is in Norway. And all these ambulances, they are equipped with a CT scanner, a point-of-care laboratory unit to assess blood coagulation parameters of thrombocytes, and they have a telemedicine connection to the stroke center. And very important, they are all staffed with stroke specialized teams.
To add something about the methodology of the guideline. So this guideline was prepared according to European Stroke Organization standard operating procedure for guidelines, following the robust grade approach. This, in simple words, means that all available data were meta-analyzed independently by the group of co-authors involved in this guideline, and we performed multiple sets of analysis, actually 27 sets of meta-analysis, in order to evaluate all clinical effects of mobile stroke units in 3 different clinical scenarios: patients with suspected stroke, patients with confirmed acute ischemic stroke, and patients with confirmed acute intracerebral hemorrhage. To the best of our knowledge, this is the first international guideline on this topic, and we were very grateful that many of the co-authors were actually involved in MSU development and MSU clinical trials, so we had also access to unpublished data in order to be able to perform the meta-analysis.
And we, or more or less you, were motivated, probably, that was your idea to start that guideline. And yes. that was based on the last 2 observational interventional studies? Correct.
Be Proud, which was conducted in Germany, and Best MSU, which was conducted in the US. And actually, these guidelines were conducted very rigorously in terms of a methodological approach, but also very swiftly, because we were able to produce the final manuscript, Silke, I think within 6 months.
Yeah, that is true. That is true. Yeah. That was a very short time. And actually, we found quite, very important and very interesting results. We found that for patients with suspected stroke, we actually probably have to start in a way that we combined all our recommendation to one recommendation only. And this is because we found that these MSU ambulances, they get dispatched to patients with suspected stroke. They will never, ever be able to get dispatched to acute ischemic stroke patients only. That is just not how ambulances operate. Because when the patients or relatives call, the call handler can only come to a suspected diagnosis. And this is why we think that it was important to summarize all our results to one recommendation. And we found that for patients who then finally get diagnosed with an acute ischemic stroke, they can benefit from pre-hospital treatment with a mobile stroke unit, and it can improve their functional outcome. They have a better modified ranking score after 3 months. More patients have an excellent outcome. This is modified ranking score 0 to 1, or good clinical outcome, modified ranking score 0 to 2. And more of them get treated. More of them, also very important, get treatment in the so-called golden hour, which is the first 60 minutes after symptom onset, when probability of survival without any disability is highest. And even also important is that we couldn't find any safety concerns. We could also not find any safety concerns for patients diagnosed with intracerebral hemorrhage. And we could find, for these patients, that more of them got transported primarily to tertiary care stroke centers. And we believe that this is important because there they can have every available and high quality care which is needed to treat these patients. For patients with suspected stroke, we couldn't identify any signal of harm, which is important. So all these others who are not diagnosed with any kind of stroke, any type of stroke, they do not get harmed by this new pre-hospital management. And we have also formulated 2 expert consensus statements. May I hand that over to you, Georgios?
First, I would like also to highlight that we showed that MSU benefits in terms of the swift delivery of TPA. So we save about 30 minutes if we treat the patients in the MSU, in contrast with treating them in the ER of a hospital. And this is very important because we know that every minute counts for acute ischemic stroke. The faster you treat the patient with reperfusion therapy, the more likely you are to achieve a very good function for this patient. So I think this was a very good quantification in the time metrics that were saved by mobile stroke unit. And with regard to what Silke alluded, with the expert opinion statements, we believe that neurological expertise was paramount in this achievement of excellent functional outcomes in patients treated with MSU. Neurological expertise was available in all the different settings of stroke units, of mobile stroke units, either with physical presence or with teleconsultation, with telemedicine. And we believe that this is the most important component of the staffing of mobile stroke unit. And I think that all co-authors involved in the guidelines, recommended as an expert opinion statement that neurological expertise should be involved in mobile stroke unit development and staffing. And I'm going to hand you over now the second expert opinion, Silke.
Yeah, the second expert opinion was on patients with intracerebral hemorrhage. And we believed, and 6 of our 8 members voted for this statement and 2 against that statement. We believe that patients with ICH, they benefit from their direct transport to tertiary care stroke centers, because in these centers, all currently available therapies can be offered to these patients. So we think that this can provide a huge benefit to patients with ICH. And of course, we do know that there are all future questions, open questions, which still have to be addressed. So future questions are certainly, and this is very much emphasized by the cost economic analysis we have heard on the International Stroke Conference. Georgios, you follow that talk. We have heard from the best MSU trial about this. Do you want to speak about that?
So this was an analysis done by Jim Grota and colleagues, and they provide evidence of MSU cost effectiveness using the gold standard of ICER. I don't want to go into many technical details, but the faster MSU is dispatched and the shorter the distance that the MSU has to run in order to reach the patient, the more cost effective is the mobile stroke unit. And this was a major concern that was raised by all reviewers that reviewed our guideline document. And we have extensively discussed this and addressed this issue in our discussion. But all co-authors shared the same point that we as physicians should be able to offer the best available therapeutic option to our patients. And the strikingly positive result of MSU care in terms of improving not only excellent functional outcome, but also good functional outcome. That means that it also reduced disability, or in favor of implementation of this novel therapy in different settings across the world.
And I think also this emphasizes that one of the future challenges and probably very, very important questions will be dispatch accuracy. So we definitely all have to, investigate a bit more in figuring out how dispatch can get more accurate. That is a worldwide problem that is not specific to one country. But in order to really get to these acute ischemic stroke patients at the moment, and probably in future times when we've got better treatments, accurate treatments for ICH patients, also to these patients, how we can get these ambulances dispatched to these patients directly and as quickly as possible. That is certainly a huge challenge. But there are also new ideas for new treatments which need an immediate and very, very quick administration. And of course, MSUs can offer the possibility to treat patients ultra early, which usually in hospitals is quite tricky. That is definitely a future perspective of these ambulances. And also there are new diagnostic equipment which can be used to make stroke diagnosis quicker and easier. And this then is quite an advantage, because the more easier we can diagnose stroke patients, the easier it will be to have more mobile stroke units on the road.
Another important challenge, I believe, is the development of novel thrombolytic therapies. For instance, tenecteplase is on the pipeline. This is a third-generation thrombolytic therapy that is administered as bolus injection instead of the current gold standard of alteplase that is administered as an infusion. And I think that the combination of tenecteplase with MSU that has not been tested today may even improve further the outcomes of the mobile stroke unit in terms of improving functional outcome and in terms of swifter TPA delivery.